So, good evening, everybody. Today we'll be talking about current concepts in intracerebral hemorrhage and when compared to ischemic stroke, intracerebral hemorrhage is not given that much importance, but it's very crucial because in Asia it constitutes about 20 to 30% cases, and in northeastern region it may be more than that, and it is one of the nasty diseases with 50% dying by the time 1 year is over after the onset, and it causes a lot of morbidity and mortality. It affects more than 1 million worldwide yearly, and 10 to 20% of the strokes are caused by intracerebral hemorrhage. In 2013, there were about 3.2 million deaths were attributed to intracerebral hemorrhage. So 68 million disability associated life years are lost compared to 39 million lost due to ischemic stroke. That means it is more devastating than ischemic stroke, and so the sufferers ought to be intervened appropriately. The subarachnoid hemorrhage constitutes about 5%, that is the bleeding around the brain. Intracerebral hemorrhage, bleeding within the brain, and ischemic stroke 85%, but 38% survival within first year in one study, 50% in another study. But in India, the ICH rates may be different in northeast regions. And if you look at they are about 20 to 30% in Asia, and up to 50% is 30-day mortality, and life expectancy is also diminished, and there is little effective therapy, and so many things have evolved. And the trend in adjusted intracerebral hemorrhage incidence in that, if you look at the trends, there is no change in the, but more and more younger people are also getting intracerebral hemorrhage in the recent years. That's a main cause for concern. And it commonly presents with headache, altered sensorium, nausea, vomiting, and the symptoms evolve rapidly over minutes to hours. The typical location of hypertensive intracerebral hemorrhage are basal ganglia, lobar regions, and thalamus, pons, cerebellum, and other brain sites. That is 1 to 5%. If you can divide the pathophysiology into small vessel disease and macrovascular disease also here, and usually the small blood vessels, they rupture and cause the end arteries in basal ganglia and lobar regions, they rupture to cause intracerebral hemorrhage. The penetrating cortical branches of the anterior, middle, or posterior cerebral arteries can be seen here. The basal ganglia is the lenticulostriate branches of the middle cerebral artery are affected here. Just show that. And thalamus, ascending thalamo-geniculate branches of the posterior cerebral artery, the thalamus can have. Pons, paramedian branches of the basilar artery, you can see them, they rupture and cause pontan hemorrhage. Penetrating branches of the posterior inferior, anterior inferior, or superior cerebellar arteries are seen in cases of the cerebellar hemorrhage. So this is their location most commonly. You can see in the diagram basal ganglia, that is putamen, thalamus, about 40 to 50%. The most common site for intracerebral hemorrhage is putamen, secondary to hypertension, that is spontaneous ICH. And the basal ganglia, lobar regions, you can see subcortical, thalamus, pons, cerebellum, and temporal lobes. So these are the various distributions which you have seen. Cerebellum is about 5 to 10%, pons is 5 to 12%, thalamus is 10 to 15%, and that's the distribution. There's a chart scale, cerebral hemorrhage anatomical rating instrument, that it charts development and assessment of reliability. And if we can maintain this chart, and you can collect the types of hemorrhages which we have seen, That will be very handy for our assessments. So as I said, the causes of spontaneous intracerebral hemorrhage, non-traumatic, will be hypertension, most common cause, about 50 to 60%, cerebral amyloid angiopathy, vascular malformations, brain tumors, hemorrhagic infarcts, arterial thrombotic or embolic and atrial fibrillation, the venous, and vasculitis or vasculopathy, sympathomimetic agents and anticoagulants and fibrinolytic agents. So these are the most common types which we are seeing. Yeah, just bit of disturbance in the thing, right? I was thinking about, did I say that? Okay, 17th. Okay, right. So the other macrovascular causes will be cerebral amyloid, vascular malformations, hemorrhagic infarcts, and symptom. So the vascular malformations are many that I'll take up in the next slide. I'll show you. But other causes will be brain tumors, the intratumoral hemorrhage, hemorrhagic infarcts, arterial and venous, vasculitis or vasculopathy, and sympathomimetic agents. Nowadays, people who take cocaine and amphetamines, anticoagulants, and fibrinolytic agents. So these are the causes of spontaneous non-traumatic ICH. There's a diagram prediction score for macrovascular etiology, and because macrovascular etiology has to be immediately identified to intervene. There are independent predictors for a macrovascular cause in patients with non-traumatic ICH: younger age, location of intracerebral hemorrhage, absence of signs of SVD, and a positive or inconclusive CT angiography. So if you have a younger age patient and lobar or posterior fossa, absence of signs of small vessel vascular disease, a positive or inconclusive CT angiography, then we should think of a large macrovascular cause and like AV malformation or something like that. You should think. So the lipohyalinosis and hyalonized vessel and arteriopathy secondary to chronic hypertension is the most common cause in 50 to 60% of the cases for hemorrhage. And the Charcot bouchard macroaneurysms, they are attributed the bleeding to rupture at points of dilatation of the walls of the small arterioles, microaneurysms. These are present at the points of dilatation, so the junctions, and the bleeding occurs at the bifurcation of the affected arteries, where prominent degeneration of the media and smooth muscles occur. So that's where the bleeding takes place. Charcot Bouchard aneurysms. The amyloid angiopathy and on hemotoxylin and eosin staining, amyloid appears an acellular eosinophilic material, which you can see here, and within the vessel wall. After staining with Congo red, the amyloid material within the vessel wall exhibits apple green birefringence under polarized light, which you can see. So the second most common cause for the intracerebral hemorrhage is amyloid angiopathy. Amyloid angiopathy, apple green birefringence, which you can see here, and this is the immunostaining method. So cerebral amyloid angiopathy is diagnosed by a set of criteria which you can have. That's got modified Boston criteria. Age should be more than 55 years. And the probable cerebral amyloid angiopathy has multiple hemorrhages restricted to lobar, cortical, or cortico-subcortical regions. Cerebellar hemorrhage allowed. A single lobar, cortical or cortico-subcortical hemorrhage, and focal or disseminated superficial cirrhosis. You can see the superficial cirrhosis here, and this is possible amyloid angiopathy is single lobar, cortical or cortico-subcortical hemorrhage, or focal or disseminated superficial cirrhosis. There are some Edinburgh criteria of the amyloid angiopathy, like if you like a finger-like projections, which you can see here, and elongated extensions arising from the hematoma, longer than they are wide, regardless of whether they extend to the cortex or not. And subarachnoid hemorrhage, if you see subarachnoid hemorrhage like this, that you can think that this individual most probably has amyloid angiopathy. So these are the two important criteria: modified Boston criteria and CT features of Edinburgh criteria. which will help us in diagnosing cerebral amyloid angiopathy. Second thing important is the cerebral microbleeds, which you can see on the SWAN imaging, or hemocytin stain deposits on gradient echo MRI, and you can see may reflect amyloid angiopathy, then present up to 20% of the patients, and the whenever they are present, they may suggest that hematoma may expand. They are linked to ICH risk after TPA also in many cases. So ICH is not a simple rapid bleeding event, and it's a dynamic and a complex process. There are two important new concepts that have come, and that is early hematoma growth. Many hemorrhages continue to grow and expand over several hours. Brain injury is secondary to inflammatory response caused by thrombin and other coagulation end products. These are the two important concepts. And mind you, so with so many decades, we have only treatment for primary primary thing. That is, you treat raised ICP, you treat hypertension, but the most of the morbidity and mortality of this disease comes because of the secondary inflammatory problems that occur in survivors of ICH cases. So the secondary is very, very important to consider. Right. Now, this is we'll see. We'll look at that. So why acute ICH kills? If you look at that, it's because of mass effect, RBC changes, and brain edema. These three things are to be remembered very much, and we have interventions which are being developed to tackle RBC changes and heme toxicity and various other aspects which I'm going to discuss in the pathophysiology. But the most important is the mass effect, and in a the cranial vault inside the brain, suddenly if there is an increase in volume because of rupture of blood vessels, the Monroe-Kelly principle says that there will be some shifts in the other two compartments. So that accordingly, immediately the individual may lose consciousness because of a spurt in raised ICP, but equilibrium sets in and he will regain also. So sudden spurt of raised ICP may make the individual lose consciousness. They usually present with headache, vomitings, and slight progression of the symptoms, like he may be shaving and there will be some weakness in the hand. Slowly he dumps, but it's not like a cardioembolic stroke where it reaches a peak immediately. So the pathological physiological changes, if you can summarize, the rapid shearing forces, increased ICP, that's a hematoma, and early neurological deterioration in 24% of cases, that is less than 12 hours because of hematoma growth, the breakdown of blood-brain barrier edema, neuronal glial cell death, apoptosis, and peri-ICH ischemia postulated, but there is little evidence and no penumbra. That's a new concept. And earlier we were worried that if we bring down the blood pressure, there will be a penumbra and there will be ischemia subsequent, but that thing is not there. So the most important concept we have to understand is perihematomal edema in acute intracerebral hemorrhage, and this is a very, very crucial thing. And if the edema is more in size, then there will be shifts in there will be herniations and death. The volume also, if it increases, and in the first 6 hours almost 33% there will be increase in the volume. You can see in this case the baseline ICH volume, and at 3 hours and 24 hours you can see the volume has increased so much, and this increase in volume was to be stopped by hemostatic agents, and earlier recombinant factor 7A was tried, but phase 3 fast trial has said that there are more of thrombotic side effects than the benefits, so it was discontinued. You can see that the pathogenic edema, which is present here, and the pathophysiology is very, very important. Pathophysiology of ICH is very important. The plasma proteins, the extravasate, then there will be clot retraction. So the two chaps, and perihematoma osmotic pressure and perihematoma hydrostatic pressure decreases, osmotic pressure increases, and a vasogenic edema. So both vasogenic edema and this vasogenic edema will give rise to cytotoxic edema. So there is an interplay between both the edemas. And you see the inflammation, how inflammation is playing a role. There is inflammatory cell infiltration takes place immediately. Neutrophils and reactive oxygen species, TNF alpha, other cytokines, matrix metalloproteases, they all the inflammation and cell swelling and blood-brain barrier disruption. So, and then another arm is microglial activation, astrocyte activation, and this all given rise to inflammatory gene expressions, which will again contribute to inflammation. So, all these things will take some time in developing, maybe about 7 days, and so for second day, third day, fourth day, and by seventh day, the edema is in full form. So if you look at the coagulation cascade, which is thrombin activation, which also contributes to the blood brain edema and the blood brain barrier disruption, you see the complement activation, microglial activation, cytokines, parts, and the inflammation and endothelial contraction, and all these give rise to basal membrane degradation. See, 2 to 6 days, 1 to 2 days after ICH, you have blood-brain disruption. So we are not tackling this part of the pathophysiology in our treatment schedules. We only reduce the blood pressure and we only reduce the ICP, but we are not at all targeting this. And the RBC lysis also will contribute. The hemoglobin that is released will also give rise to the blood-brain barrier disruption and brain edema, and iron deposition, toll-like receptor 4 activation, and again cytokines are released, microglial activation. So these are the main issues: the thrombin, RBC lysis, heme, and microglial activation. These are things which will bother us much. And you can see the hematoma, early clot removal is one attempt which we can see. And because the hematoma can be intrahematomal growth edema or perihematomal edema. So if you remove the hematoma, there will be the scope for improvement. So that's why surgery is immediately required for tension hematoma. Clot retraction, hydrostatic pressure is decreased, plasma proteins come out, then they cause osmotherapy and vasogenic edema. Thrombin activation and cytotoxic edema. See, the vasogenic edema surrounding areas, they become oxygen deprived. So there will be activation of all these oxygen species and they cause cytotoxic edema. And so both these things will have a bad prognosis. So now we know that pathophysiology, these are so many things. So what is the neuroimaging in intracerebral hemorrhage? The hematoma changes in MRI. They are hyperacute, acute, early subacute, late subacute, and chronic are to be learnt really. And you should understand what are these changes, and you have to know how to calculate the hematoma volume, and also you have to see that hematoma expansion signs. You have to learn them at what are the hematoma expansion signs. So evolution of parenchymal hemorrhage, you can say hyperacute means less than 24 hours, acute means 1 to 3 days, and early subacute means more than 3 days, late subacute means more than 7 days, chronic is more than 14 days. And the compartment wise, the oxyhemoglobin is intracellular in hyperacute, deoxyhemoglobin is intracellular in acute, and intracellular methemoglobin is early subacute, and late subacute it is extracellular methemoglobin, and chronic it is hemosiderin extracellular. And these various hemoglobins will give rise to different changes in the imaging characteristics. And you can see that in the hyperacute, the T1 is isointense and that is bright, T2 is bright, and acute it is iso-intense and T2 is dark. This is less than 24 hours and this is 1 to 3 days. And early subacute, that is 3 to 7 days, this is T1 is bright and T2 is dark. And last two you can easily remember: late subacute, that is 7 to 14 days, both are bright, T1 and T2, and both are dark if it is more than 14 days. So it be iddy biddy baby do. So this is a type of mnemonic that has been coined, but you remember that hemosiderin more than 14 days, it becomes dark on both sides. Okay, so that's important to remember. And volume calculation, you can take an axial CT scan and ABC by 2 method. Since the largest area for the thing which you pick up, measure the largest diameter, and perpendicular to that also you measure. the count of the slices. ICH is seen on zero 0.5 centimeters, 5 millimeters cuts or 10 millimeter cuts. You see the scale, and that is the thickness. So if you look at A is 6 centimeter, B is 3 centimeter, there are 6 slices which are of say 5 millimeter thickness, then you can have 3 centimeters. Hello? Yeah. Actually, no, I am in a class. Can you call me after 1 hour? Okay. Yeah. So hematoma volume is 6 into 3 into 3 by 2, that is 27 cc. So this is to be calculated because this is very, very important for us to understand about ICH score, which we are going to calculate. So volume calculation is one of the important things the resident should learn about ICH management. And gradient echo, of course, will tell you various other aspects where blood can be seen, hemostatin can be seen, right? And the cirrhosis can be identified, and these are the gradient echo images. You may find some of the small vessel vascular diseases, and whenever you find some small vessel vascular disease, you can be assured that it is arteriopathy secondary to hypertension. If you see an image where there are no small vessel vascular disease signs, then the macrovascular pathology is to be suspected in ICH. The CT and MRI of the patient with intracerebral hemorrhage and subsequent clinical ischemic strokes. So there are studies which have shown that ischemic changes will appear post ICH cases on DWI images and some studies. So how do you predict the hematoma expansion? As the most important for us is the spot sign on CT angiography. That is a single positive sign which you can see here, and which will tell this is the total hematoma volume at 19.6 ml, baseline non-contrast CT, and 24 hours later, when you see this CT sign, when you did a baseline CT angiography, then you see the enlargement, and that has become 110. So this is the spot sign, but there are other signs also which this requires CT angiography, but you may see some other signs which will say that no, you can expect expansion of the hematoma, which I'll show you. This is also again a CT spot sign, and you can see this again like a CT spot sign, which is giving rise to enlargement of expansion. And as I said, expansion or hematoma expansion takes place in the first 6 hours in 33%. 33% increase in the volume will happen in the first 6 hours. It goes on happening till 24 hours. So whatever interventions which you have to plan accordingly. This is a blend sign. A blend sign appears as a mixed density hematoma with two well-defined components, a relatively hyper-attenuating area adjacent to the hyper-attenuating area, but you can see, and further CT densitometry reveals that the hematoma have more than 18 Hounsfield units difference between the two density regions. So that's one of the things. If you measure the Hounsfield units, then you can easily calculate this. So that's one of the things which you should see. There's a swole sign. It's defined as a region of hypoattenuation or isoattenuation within the hyperattenuated ICH. And the area of hyperattenuation or isoattenuation may vary in shape and can be rounded or star-like. So this is the second sign. We learned about bend sign and the swole sign, and some modified spot sign obtained using CT perfusion, venous phase CTA, post contrast CTA, and 90-second delayed CTA. So various studies have done. One shortcoming of spot sign is that the blood vessel within a hematoma may resemble a spot sign. Using continuous CT angiography, source images could exclude blood vessels and improve its accuracy and diagnosis. So these are the this is what we said: blend sign. There's a black hole sign also, island sign, satellite sign. These are various signs of CT scan, normal NCCT, which will help us in deciding that the hematoma may expand. So there is a brain score and a
Sir,
bat. Yes, please.
hello.
Yes, please. Hello.
Slides are not seeing, sir.
Signs are not
Hello.
seen. Okay,
Sir,
okay.
screen is not seeing.
I'll just share it again then. Just wait, okay? Yeah, but what happened? Why it's not seen? 1 second.